Hi everybody and welcome to our module on breast carcinoma. Breast carcinoma is the most common non-skin cancer in women, and it is the second most deadly cancer in women, second only to lung cancer. It's mostly a disease of older postmenopausal women. It's very rare before age 25, and the incidence increases after age 30 and peaks at about 70 to 80 years old. And it can occur in men, although this is rare, and we'll talk about this at the end of this video. Let's talk about some of the risk factors for breast carcinoma. So female sex is a major risk factor. 99% of cases of breast carcinoma occur among women. Age is also a risk factor. As I mentioned on the last slide, breast carcinoma is rare in younger women and it's more common in older women. The peak incidence occurs between 70 and 80 years of age. And then having a first-degree relative who has breast cancer raises a woman's risk of breast carcinoma. This usually means either a mother, sister, or daughter with breast cancer. Breast tissue is hormone sensitive, so it should make sense to you that when there is increased estrogen exposure, this can potentially drive breast tissue to turn into carcinoma. So women who have early menarche or late menopause have a longer period of time during which they are ovulating. This leads to more estrogen exposure and more risk of carcinoma. Obese women have lots of fatty tissue, which converts androgens into estrogens, and this leads to more estrogen exposure and raises the risk of breast carcinoma. And then finally, women who have children and breastfeed have a lower risk of breast carcinoma. Breastfeeding is protective, and that's because women do not ovulate when they are breastfeeding, and that leads to less estrogen exposure. Another risk factor is the age at first live birth. So women who begin having children when they're very young, less than 20 years old, have a lower risk. This is a protective factor. Women who have their first child when they're older, greater than 35 years of age, are at higher risk for breast carcinoma. Breast carcinoma is usually detected in one of two ways. First of all, the woman or her physician may palpate a breast mass. And second, mammography is a screening method to detect breast carcinoma. Mammography is a special type of X-ray which takes an image of the breast, and microcalcifications will show up as bright white. And microcalcifications are often seen in malignant breast lesions. Now, there are other benign breast lesions which also can lead to microcalcifications. These include fat necrosis and sclerosing adenosis, plus a number of other conditions. I talk about all of these things in the video on breast disorders, but the point here is that mammography is a screening tool, and when microcalcifications are seen, that indicates the need for a further workup to determine whether or not the woman has a breast carcinoma. We'll talk about all the major types of breast carcinoma in this video, but first let me go over how breast carcinomas are named. So breast carcinomas are divided into ductal versus lobular carcinomas. Ductal carcinomas get their name because the cancer cells resemble duct cells. Lobular carcinomas are named because the cancer cells resemble lobules. And it was once thought that carcinomas came from different places. In other words, that the ductal ones came from the ducts and the lobular ones came from the lobules. It's now known that all carcinomas, ductal and lobular, come from the terminal duct lobular unit, which is this structure shown at the bottom of the screen. I discuss it in more detail in the video on breast tissue. So even though these tumors are still called ductal or lobular based on their histologic appearance, they all arise from the terminal duct lobular unit. And then secondly, carcinomas are divided into in situ versus invasive. So in situ carcinomas are those that are still contained by the basement membrane. Invasive carcinomas have broken through the basement membrane. Almost all, 95% of breast carcinomas are adenocarcinomas. They arise from the epithelial cells of the ducts and lobules in the terminal duct lobular unit, and at diagnosis, more than 70% of them have already invaded the basement membrane. Let's start by talking about ductal carcinoma in situ. DCIS is a malignant growth of epithelial cells from the terminal duct lobular unit. DCIS gets its name because the malignant cells usually fill the ductal lumens. That's why it's called ductal, but they are constrained by an intact basement membrane. That's why it's called in situ. There are a number of patterns of DCIS, but shown on the screen is a fairly classic example of the cribiform pattern. This is an example you should be able to recognize for the Step 1 exam. The malignant cells are constrained by the basement membranes, so they tend to form these well-defined circles and ovals like shown in this example. This is called the cookie cutter pattern of DCIS because the cancer cells produce these secretions which form these circles in the middle of the lesion. These secretions can sometimes become calcified and lead to microcalcifications that can be detected on mammography. What this means is that ductal carcinoma in situ lesions form microcalcifications in many cases, and this is in contrast to lobular carcinoma in situ, which does not form microcalcifications. We'll talk more about LCIS in a minute. Now, because DCIS lesions are constrained by the basement membrane, they're usually relatively small and they're usually not picked up as a palpable breast mass. Instead, the microcalcifications are usually detected by mammography. This is the way DCIS is usually identified. A mammogram is abnormal and that leads to a biopsy which shows DCIS. There are many subtypes of DCIS based on histology. One is the cookie cutter pattern I showed you on the last slide. That's called the cribiform pattern. Another pattern is called the comedo DCIS pattern. In this type of DCIS, there's central necrosis. This is an example of the comedo form shown on the screen here. This purple lump in the middle of the DCIS is central necrosis. In addition, the tumor cells are large with pleomorphic nuclei, and this subtype of DCIS is particularly high risk for subsequent development of invasive carcinoma. Now, in general, DCIS is a good example of how a screening tool can lead to prevention of disease. These lesions are usually picked up by mammography. Once they are identified, the woman is offered treatment, usually with surgery and also sometimes with radiation and chemotherapy, and this prevents the development of invasive carcinoma by identifying a lesion before it has become invasive. Next, let's talk about Paget disease of the breast. Paget disease is a clinical presentation of breast cancer. It refers to erythema at the nipple due to an underlying malignancy. This is a picture of what Paget disease of the breast looks like, and although it's rare, some women with breast cancer present with this type of lesion around the nipple. This can occur when there is DCIS that extends to the nipple. It can also be seen with invasive cancer. Both DCIS and invasive cancer can cause this presentation. And what happens is the cancer cells penetrate the lactiferous ducts and then they migrate up to the nipple. This causes fluid to leak into the ducts, and then the fluid leaks out of the nipple and forms a crust, and that's why you get the red lesion around the nipple. The hallmark is the Paget cell, which you can see when you biopsy this red area around the breast. The presence of Paget cells makes the diagnosis of Paget disease. Paget disease is a rare clinical presentation of breast cancer, but when it occurs, there's a very high chance that the woman has an underlying invasive carcinoma. In about 50% of cases of Paget disease, a palpable mass is identified on breast exam, and about half of women have a mass identified by mammogram as well. Usually these masses turn out to be invasive carcinoma. So as I said before, DCIS can cause Paget disease, can cause the clinical presentation of Paget disease, but it may also be caused by invasive carcinoma. Next, let's talk about lobular carcinoma in situ. This is a proliferation of cells in the ducts and lobules that is limited by an intact basement membrane. The distinction between DCIS and LCIS is based on histology. This is what LCIS looks like shown on the screen here. You can see that it has a very different appearance from the pattern that we saw before for DCIS. Remember what I told you before. It was once thought that ductal and lobular carcinoma in situ had different origins within the breast. We now know that these growths all come from the terminal duct lobular unit, but they have different appearances under the microscope because the cells have different characteristics. What makes the cells in LCIS unique is that they display what's known as discohesive growth. These cells have loose intracellular connections, and the reason for this is because they have lost the adhesion protein E cadherin. It's very high yield to know this. For this reason, the cells become round and they all lump together. They don't form any fancy shapes, and that's why you get these circular bunches of round cells under the microscope. As I mentioned before, lobular carcinoma in situ does not lead to microcalcification, so you may be wondering, how is this lesion detected? It's small because it's contained by the basement membrane, so it usually doesn't lead to a breast mass, and it doesn't produce microcalcifications that you can pick up on mammography. So the way that this is usually identified is as an incidental finding on biopsy. So a woman has a breast lump or an abnormal mammogram and she gets a biopsy, and incidentally LCIS is identified. It's often bilateral and it may be multifocal, so when you see it in one portion of a biopsy, it may also be present in another. The best way to think about LCIS is really that it's a risk factor for invasive carcinoma. The lesions themselves are non-invasive and have a low chance that they will go on to become carcinoma. However, any woman who has LCIS identified on a biopsy has a risk of carcinoma in both breasts. Unlike with DCIS, it doesn't make sense to simply remove the single LCIS lesion because usually multiple lesions are present in both breasts. Now, the management of women who have LCIS identified on a breast biopsy is complex and beyond the step 1 level. But one thing you should appreciate is that management of women who have LCIS identified is often with chemoprevention using drugs like tamoxifen. Tamoxifen is a SERM, which stands for a selective estrogen receptor modifier. It's a drug that has a structure similar to estrogen as shown on the slide here, and it blocks estrogen effects at breast tissue and therefore reduces the risk of breast cancer. And women who have had LCIS identified by a biopsy because they are at higher risk for breast cancer are often administered tamoxifen to lower their risk of developing invasive carcinoma. Now let's talk about invasive breast carcinoma. The most common type of invasive carcinoma, 80% of cases, are invasive ductal carcinoma. They're usually identified as a breast mass or from an abnormal mammogram, and a biopsy shows duct cells with stroma. This is an example on the screen here. You see clumps of these purple ductal cells which are cancerous, surrounded by pink stroma. Most commonly, these tumors develop in the outer quadrant of the breast. There's more breast tissue here. So if this is a woman's breast and this is her midline where her sternum is, and this is the lateral portion of her body, up here is where about 50% of cases of invasive ductal carcinoma occur. Next, let's talk about inflammatory carcinoma. Inflammatory carcinoma is really a clinical presentation of invasive breast cancer. It doesn't necessarily imply a specific subtype. It can be seen with lots of different histologic subtypes of invasive cancer. Women who present with inflammatory carcinoma present with erythema, which is redness and swelling of the breast. In addition, their skin takes on a dimpled appearance that looks like an orange rind, and for this reason, inflammatory carcinoma is sometimes called peau d'orange. The reason some women with breast cancer present this way is because the tumor invades the skin or the dermal lymph vessels and blocks the flow of lymph out of the breast skin. This causes the skin to swell, and then underlying connective tissue pulls on the skin, giving it that dimpled appearance. This sometimes mimics infection because it's red. It can look like cellulitis or mastitis, and some women are initially misdiagnosed. Tumors that cause the clinical presentation of inflammatory carcinoma are usually high grade and carry a poor prognosis. Much less common than invasive ductal carcinoma is invasive lobular carcinoma. This accounts for only about 10% or so of all breast carcinomas. There's just a couple of things you should know about invasive lobular carcinoma. First of all, the cells tend to grow in a single file, and just like LCIS, this is because of lack of E-cadherin adhesion protein expression. The cells can't stick together in clumps. So shown on the screen is a pretty classic example. You've got cancer cells growing in a single file, which is relatively unusual. And then just like LCIS, invasive lobular carcinoma is more likely to be bilateral with multiple lesions. These types of cancers tend to occur not just in one spot in the breast. Let's talk about the prognosis of breast carcinoma. The presence of axillary lymph node metastases is the most important prognostic factor. These tumors spread through the lymphatic system, and the first place that they go are to the lymph nodes in the axilla, and you can detect metastases here by biopsy. And usually a special type of biopsy is done to look for axillary node metastases. It's called a sentinel node biopsy. In this type of biopsy, the surgeon injects a tracer into the breast and then sees which of the lymph nodes it goes to first. The surgeon then dissects those lymph nodes first and checks for cancer. If they are free of cancer, the surgeon stops the operation. This allows the surgeon to perform a smaller operation as opposed to dissecting all the lymph nodes and checking each one individually. If the first set of lymph nodes is positive for the tracer, then the surgeon goes deeper and deeper until the area is identified where there is no tumor present. There are also some markers present on the tumor cells that are very important for prognosis and also for therapy. So breast cancers are checked to see whether or not they are positive for the estrogen receptor. Tumors that are called ER positive. These tumor cells are also checked to see whether they're positive for the progesterone receptor. If they are, they're called PR positive. And finally, they're checked to see whether they express the human epidermal growth factor receptor HER2. So you can classify these tumors as ER positive, PR positive, or HER2 positive, and this has implications for prognosis. Another basic science thing I want to point out that's high yield for step one is that estrogen and progesterone are steroid hormones. They have structures like what I've shown on the screen here. So their receptors are found in the cytoplasm and they exert their effects on the nucleus. HER2 is a cell surface tyrosine kinase receptor, so this receptor will be found on the surface of cells, and that's the kind of cell biology tie-in that they like to ask you about in the step one exam. Not only are these markers important for prognosis, they can also help in choosing medical therapy for breast cancer. So women who have tumors that are positive for the estrogen receptor and progesterone receptor may respond to the drug tamoxifen. Tamoxifen is a selective estrogen receptor modulator, or a SERM, and I talk about this in videos in the hematology section on cancer drugs. HER2 positive tumors may respond to the drug trastuzumab, which is a monoclonal antibody against the HER2 protein. And I also talk about this drug in the hematology section. Some women have what's known as triple negative tumors. These are tumors that are ER negative, PR negative, and HER2 negative. These tend to be highly aggressive tumors, and they often occur in younger women under age 40. Most cases of breast cancer are sporadic, but about 10% are familial, meaning that they are caused by gene mutations that run in families. And the BRCA1 and BRCA2 genes are the genes that are most commonly mutated in familial breast cancer cases. BRCA1 and BRCA2 are named for breast cancer. The BRCA stands for breast cancer, and mutations of both genes are associated with breast cancer, and they cause about 85% of single gene familial cases of breast carcinoma. Both BRCA1 and BRCA2 code for DNA repair proteins, so when these genes are mutated, the DNA repair proteins are not produced normally and DNA damage can occur, and that can lead to cancer. These genes are famous for their association with breast cancer, but you should know they're also associated with other malignancies as well. In particular, BRCA1 is associated with ovarian cancer, and BRCA2 is associated with male breast cancer, which we'll talk about in a minute, and also pancreatic cancer. In families with the BRCA1 and BRCA2 gene mutation, it's passed down to an individual as a germline mutation, meaning a person inherits it and has an abnormal BRCA1 or BRCA2 gene in all the cells in their body. It's transmitted in an autosomal dominant fashion, but it displays incomplete penetrance. I talk about incomplete penetrance in videos in the genetics section, but what this means is that not all individuals with the disease mutation will develop disease. And so this makes genetic counseling challenging, because a woman who inherits the BRCA1 or BRCA2 gene may or may not necessarily develop breast cancer later in life because of the phenomenon of incomplete penetrance. I'll finish with one slide on male breast cancer. Carcinoma of the breast can occur in men, but it's rare. The incidence is 1% compared to the incidence in women. It usually occurs in older men, about 60 to 70 years of age, and it almost always presents as a mass near the nipple, usually a subareolar mass, sometimes with discharge. And this is because most breast tissue in men is right near the nipple. And there are two key associations you should know for male breast cancer for step 1 of your boards. First of all, about 3 to 8% of cases occur in men with Klinefelter syndrome, which I discuss in a video in the genetics section. And as I mentioned just a minute ago, BRCA2 gene mutation carriers who are men also can develop breast cancer. About 4 to 14% of cases of male breast cancer occur in families with a BRCA gene mutation. And that concludes our video on breast carcinoma.